All right, is that showing up? Everybody see that? Okay. All right, so good morning. Thanks for enduring hours of Zoom. And so for this talk, we'll be going through evaluation and treatment of the patellofemoral joint. So, just to be clear, no disclosures for this talk. As an outline, I think first it'll be helpful to review anatomy and factors that can predispose to injury. And then talk about some of the issues that we see with the patellofemoral joint. So patellofemoral syndrome, instability, and then we'll kind of skip over cartilage injuries, or we'll cover a little bit, but I know that Dr. Feely discussed that last week with a good focus on patellofemoral cartilage, so we won't spend so much time there, and then a couple cases at the end. So with the patellofemoral joint, the patella, is a sesamoid bone within the quad tendon and the extensor mechanism. And then there are 7 total facets. And then, we'll think of this largely as like the lateral facet and the medial facet. And then those are broken into the superior, middle, inferior, and then there's the odd facet. And the patella has just the large central ridge, and then the articular regions on the medial and lateral sides. And then for support, you have the medial and lateral retinaculum. And the medial patellofemoral ligament is our important restraint on the medial aspect that limits the likelihood of lateral dislocation. And there's also lateral patellofemoral ligament. All right, so what are some of the structures that keep the patella stable? Let's just kind of go around it. And Kaz, just give me one that contributes to stability.
So like the medial patellofemoral ligament.
Okay, great. And let's see, Joey.
Yeah, I guess, there's bony stability too, just with the trochlear.
Yeah, so the trochlear.
Can I ask a quick question, Dr. Lansdown?
Yeah, of course. And interrupt anytime.
Just the layers. So like there's your retinaculum, your MPFL, and like in capsule. And I guess I've always like what you're hitting first and like what those layers are and where we should be looking, in our dissection.
Yeah, and so the MPFL is just superficial from the capsule. So that third layer is the capsule, and the MPFL is kind of between, or just superficial to that. It's beneath the VMO, and then it's an extra-articular structure. So when you're reconstructing that, you do want to just stay outside of the knee joint itself, but want to be just right along the knee joint capsule. And okay, so you said like kind of the bone shape, so the trochlear shape, the patella shape can also contribute. We have the soft tissue structures from Kaz. Charlie, what else can contribute to patellar stability? Unmute.
We talked about the MPFL in terms of ligaments, but the there's also the quad tendon and the patellar tendon, which contribute stability.
And what specifically on those?
I mean, those contribute to patella baja and alta, so more in the sagittal plane.
Yeah, so patellar height, so that can definitely contribute. And then, oops, I got an echo somewhere. Let's see, Ryan, what else could we see? Or Marcus, I think.
I think VMO could be pretty important too. Like if you're, besides the actual tendon, like the quad function itself is going to help push it over.
Yeah, and we can lump that into the soft tissue bucket. And just a few more. So your overall knee alignment. So if you're in a large degree of valgus, you'll have an increased lateral force vector pulling on the patella. Femoral rotation. So if your femur is really internally rotated, that will push the patella out laterally. Tibial rotation as well, similar concept. And then the tubercle position. So the more lateral the tibial tubercle is, the greater the lateral pull on the patella, the extensor mechanism. And then those soft tissue structures, so MPFL, the VMO, et cetera. So kind of going through these. So, one important one is the trochlear shape. And so the normal trochlea should have a lateral aspect that's more anterior than the medial side. So the lateral side's higher. And then we'll talk about the sulcus angle. So this angle formed by the trochlea, and normal is about 132 to 138. Does anybody know some of the radiographic signs of trochlear dysplasia?
You can have a crossover sign.
Yeah, so a crossing sign, and that's just where that lateral trochlea is. It's not, it's lower down, and then so you don't have that like bony geometry to keep the patella, from translating laterally. And these top images, so what we're seeing here is like you can find these different structures on your lateral x-ray. And so, this normal lateral aspect of the trochlea, that will be the most anterior part. And then the medial aspect of the trochlea will be your next line. And then the center of the groove will be the lowest line. And so, when you have that crossing, like those lines are crossing, you don't have that groove down there. And so then that's a sign of trochlear dysplasia. And, for classification, we'll use the de Jour classification. Have you guys heard of that for trochlear dysplasia?
Mm-hmm. Yeah.
De Jour has broken this into 4 different types, A, B, C, D. The classification is based on that lateral x-ray and based on kind of what you see. And the type A is just a shallow trochlea with the sulcus angle greater than 145 degrees. So this is just approaching a flatter groove rather than, more normal, deeper groove. With that, you see the crossing sign because you don't have that nice deep groove the whole way down. The type B is a flat trochlea. So we've gone from shallow to flat. And with that, you see a supratrochlear spur. You don't have that normal morphology of the groove, and it's just flat across there. So that spur is reflected on the lateral x-ray. And then type C has this lateral convexity in medial hypoplasia. And with that, you see this double contour on the lateral x-ray. So if you're imagining this in that projection, and then type D has the supratrochlear spur and the double contour. And then this is a cliff. These are important. Most of the time, we're not talking about altering the trochlea, but it's important to recognize, if they're dysplastic, because that can be a risk factor for ongoing instability. All right, and then on the patella, the Weiberg classification is probably the best one to look at per patellar morphology. And with this concave medial facet that's almost as large as a lateral facet. And then B, you have this large lateral facet and then a smaller medial facet. And then C, you have just this vertical medial facet, and it's almost just all lateral facet. The Weiberg classification, like it may be a risk factor for instability. A lot less is shown related to patella morphology than trochlear morphology, but something to look at and keep in mind as you're evaluating these patients.
For this classification, is A considered normal, or is this all pathologic?
Yeah, A or B. Like these are kind of the more normal types of patellas that you'll see, and then C's more abnormal.
Whereas the last classification system was all pathologic. Okay.
Correct. Yeah, so any of these are dysplastic trochlea, and it's just kind of breaking those into these different typical morphologies
Okay,
that we'll see.
thanks.
Yeah. And then, hold on one second. Okay. Charlie mentioned patella alta, patella baja, so that patellar height. And we know that patella alta is a risk factor for patellar instability. When the patella is positioned more proximally, it takes longer for it to engage in the trochlea, and then may, track abnormally before it, really engages. So the longer it has to travel, the greater chance that it won't find the proper position as it's coming down. And in evaluating, this in the setting of patellar instability, so 24% of patients with patellar instability have alta, whereas it's seen in only 3% of patients with a stable patella. So, that patellar height can really contribute. And then let's see, Anthony, what are some ways that we can measure patella alta?
We can use the insole cell body ratio, which is a proportion of the length of the patellar tendon over the length of the patella. You can use the Caton de Champ, which is the length of the inferior pole of the patella to the articular margin of the proximal tibia over the length of the articular surface of the patella. And then there's also like a Blackburn peel, which uses a line perpendicular to the surface of the tibial plateau, and then you can use that distance to the pole of the distal patella over the articular surface. Yeah. So.
Okay, so let's say you have to pick just one to always use for patellar instability. Which one would you choose?
I would use maybe the Caton de Champ seems most reliable in terms of. I feel like the patellar length itself can be quite variable. So just looking at the articular surface could be more reliable.
Yeah, exactly. And so, the way that you describe it is exactly right. So you're measuring the articular surface, and then from the inferior aspect of the articular surface to the anterior superior tibia, so to the joint line. And this is really telling you where that patella is relative to the tibiofemoral joint. And, some advantages, measures the articular surface of the patella, so it's not influenced by abnormal bone proximally or distally. And then I think a big one is it's independent of the tibial tubercle. And so if we're saying that a patient has patella alta, and then we're going to distalize their tubercle, they have a functionally long patellar tendon. Their tendon length would still be the same even afterwards. So that insole Salvati ratio would not change. But then the Caton de Champ, that position of the patella relative to the tibiofemoral joint, that would be different. And then there are times where it's hard to make out a tubercle, especially on some of these more dysplastic patients. And so it can be challenging to identify exactly where the tubercle is. So I think, Caton de Champ solves that by just referencing off of the joint line. So I think it measures more of what you're interested in. It can be used pre-op and post-op after distalizing someone. And it's also validated on X-ray, CT, and MRI. So I would recommend the CDI as kind of the go-to measurement of patellar height. Does that make sense to everybody? All right. And then the other thing, whenever we're talking about an osteotomy and distalizing someone, if your X-rays are calibrated, you can decide how much you want to distalize based on that. So, you can say, I want to target this as my final CDI. And then if I distalize by 5 millimeters, this will be it. If I go 8, and then so you can know exactly how far you're going to bring them down to achieve that result. And then normal for this is 0.8 to 1.2. The higher you get, so the higher so it's measured as B over A. And then the higher you get, the more alta. And then the lower you get, the more baja. And so yeah, 1 point above 1.2 will classify as patella alta. All right. So in addition to trochlear shape, patellar height, the overall limb alignment contributes to patellar stability, and valgus alignment especially adds an increased lateral force on the patella. And then, so this is an increase in the Q angle, the quadriceps angle. So that's, kind of what you'll look at, in clinic, looking at their valgus and their overall knee alignment. And then we know that miserable malalignment syndrome, femoral anteversion, genu valgum, tibial external rotation, and foot pronation. You can see in this picture on the right, and can just imagine, the quads coming from here, attaching here, and then everything will be pulling that laterally. And so femoral rotation, that can contribute also. That increased internal rotation of the distal femur places a increased lateral pull on the patella. And to evaluate this, so with patellar instability patients, I'll check their hip rotation in clinic. And then generally just looking to see if their unstable side has excessive femoral anteversion. And then if clinically it looks like, they have a large difference or have extreme internal rotation, then we can get either a CT or MRI scanogram. And with that, you want to just have the hips and the knees. A lot of times they'll kind of skip in between, so you're limiting the radiation dose of getting a CT. But you have to be able to get the femoral necks and then the distal femur. And then you're measuring the angle of the femoral neck relative to the horizontal, and then the angle of the posterior condyles relative to the horizontal. And normal should be about 10 to 20 degrees. And then if you have a difference, more than 10 to 20 degrees, it may be worth thinking about even like an osteotomy to correct their anteversion. And what you don't want is to overlook that the problem is just proximal and you're treating all distally and then not really solving the problem that they have. This type of measurement has shown up on in-training exams, so would just kind of remember how to measure that and how to compare between the sides. And then tibial rotation is similar, and increased external rotation of the tibia can be a risk factor, as that also, externally rotating the tibia will lateralize the tubercle. So we'll lateralize that force on the patella again. And you're, just looking at that horizontal line, posterior border of the tibia, anterior border of the talus, and then normal should be about 15 degrees. And then more commonly, what we'll see is that you'll have a lateralized tubercle. So that tubercle position, just the insertion of the patellar tendon will increase the lateral force vector on the patella. And then this is what we look at with the TTTG, the tibial tubercle trochlear groove measurement. And that's been validated on MRI or CT, any cross-sectional measurement. And you're just looking at that offset of the tubercle relative to the trochlea. So how far lateral is the tubercle? And then with this, so normal, it should not be 0. Like normal is like 10 to 12 millimeters. And then abnormal is definitely above 20 millimeters. And then in the 16 to 20 range, it's kind of a gray area. And that can be abnormal, can be normal for that patient. But this is definitely an important measurement to understand and to know. Does that make sense to everybody? Okay. And then an additional measurement is the TTPCL. So this is similar to TTTG. You're looking at just that lateral offset of the tubercle, that increased lateralization of the patellar tendon attachment, but referencing off of the PCL instead of the trochlea. And this one, we don't use as commonly, but when you're looking at a really dysplastic knee, sometimes it's hard to say like this is the middle of their trochlea because you don't have a groove. So if you remember that that type B where you just have a flat trochlea, you can't say like this is the bottom or if you have that D where it's just, you know, you have a cliff and it's hard to say like this is center of the groove. And then so the PCL can be a good central fixed reference point. And then it may be less affected by rotation of the knee too. And then, you know, just to keep in mind, so abnormal for TT PCL is just a little bit higher, but 24 millimeters. I don't think you'll see this on any tests, but as you're evaluating these patients, I think it's useful if you say like, I can't really say where their trochlea is. You can still measure offset with this measurement. All right. So then we've kind of gone through bony anatomy. We'll go to the soft tissue. And then really the one of interest is the MPFL. And so this is a distinct ligament. I think, you know, last year, I think it was last year that we did MPFL reconstruction in the lab. Might be mistaken on that, or it might be 2 years ago. You can find that ligament medially. It is anterior to joint capsule, as we talked about earlier. And then this figure, these relationships often do pop up on tests. They're highly applicable in surgery, but you know, good to understand where these structures are relative to each other. So the MPFL, the femoral attachment is here. You have the adductor tubercle just proximal and posterior, and then the medial epicondyle, distal and anterior. And intraoperatively, you can feel the adductor tubercle and the medial epicondyle well as you know, surface anatomy. And then there's kind of a saddle area where the MPFL attaches, and that's what we're looking to you know, to reconstruct, is that relationship. And then on the patella, the midpoint was 41% of the length from proximal to distal. And so the important thing to keep in mind here is that when we're reconstructing this, usually we'll do 2 points of fixation on the patella, but both above the equator. So you don't want anything distal to the equator of the patella, but every, like, you know, 2 anchors proximal. Usually put one just right in the middle and then right at the kind of the superior medial corner, like as it's starting to turn around. The MPFL, so it is a check rein to lateral translation. And it's not, you know, like a constitutively active ligament, but what it should do is, as like every patella should have some lateral translation, but this is just as you're laterally translating, it won't let you go past a certain amount, and then we'll tighten at that point, and then the patella will return centrally. All right. So now we'll kind of go into a few you know, clinical conditions that we'll see commonly. And one of the more common things that we see is patellofemoral pain syndrome. So does anybody know how these patients present?
Usually have anterior knee pain, particularly going up or down stairs. So times that you've got increased stress in the patellofemoral joint, or like kneeling or things like that.
Yeah, perfect. So this is anterior knee pain, like you said, stairs, hills, running, and then they'll often have pain with prolonged sitting. So that's like the movie theater sign. That's like, you know, I sit for a couple hours, my knee really starts to hurt, I need to get up and move it. Yeah, usually this is all pointing you towards patellofemoral pain. It can often start with a change in activities or, you know, decreased conditioning, and then trying to ramp up with something new. The exam is usually benign, unlikely to have an effusion. Patellar grind can be plus or minus. Patellar tracking is usually not abnormal. And then oftentimes these patients will have a poor single leg squat, reflecting like the abnormal dynamic control of the patellofemoral joint. They can also have tight hamstrings. And then usually the single leg squat will kind of reproduce the pain that they feel in the front of the knee, because they're really loading that joint. They're not able to control the patella with the dynamics, you know, muscular support, and kind of overloading that joint as a result. And if you're seeing an effusion, would have a higher suspicion of like a patellar cartilage injury. You know, an effusion in the absence of arthritis should really be further evaluated, you know, with an MRI, further diagnostic studies to make sure that there's not something else that you're missing. Treatment for patellofemoral pain syndrome is basically always physical therapy with a focus on quad strengthening and then really like core and abductor strengthening. I think more people are deficient in the core and hip strengthening than they are in quad strengthening. And usually it's kind of a mismatch between the two, but more focused on you know, hip abduction. And then also focusing on hamstring stretching. Sometimes McConnell taping can help symptomatically, but most of the time we can get these patients better with these non-surgical interventions. So patellar instability, overall, it's more common in women and then caused by direct trauma and lateral force on the patella. And you'll have contraction of the quadriceps, external rotation of the tibia, leading to that lateral pull on the patella. So you can see his kneecap is dislocated there. May self-reduce. A lot of times it'll just pop right back in or may need assisted reduction. And let's see, Joey, do you know how to reduce a patella if you have somebody in the emergency room?
Yeah, I'm pretty sure you just kind of extend the knee and kind of guide it back in with your hand.
Yeah, exactly. So you just straighten the knee. So if you see one of these, like an athlete on football field with patellar dislocation, just you know, try to straighten the knee, push the kneecap back central. Yeah, and then these patients will have a large effusion. So we talked last week about ACL and kind of that differential for the acute traumatic effusion, and patellar dislocation is one of them. And you know, just remember that this story can be the same as the ACL. Like I planted my foot, I twisted, pivoted, because that can give that increased lateral pull on the patella. They can feel a pop from the kneecap and then have that large amount of swelling. So you'll really, you know, differentiate that on exam.
Would you keep that athlete out of the rest of the game if they
Yeah.
had a patellar dislocation?
Yeah. And yeah, because it'll, especially like right away, have a increased risk that it'll just happen again.
Yeah. And the immobilizer, you think, or do you give them any restrictions for the first week or so?
Yeah, depending on how, but you know, usually you can do like a patellar stabilizing brace that just has like a lateral buttress so the kneecap doesn't track laterally. But you know, encouraging motion should be fine. And then, so when we're evaluating these patients, we'll look at patellar translation. So let's see, Stephen, do you know how we do this and how we measure it?
Yeah, the quadrant method. So you can divide it to 4 quadrants. Usually going out 2 is normal. Anything more than that is abnormal.
Yeah, and I would just,
50%.
and then what position is the knee in?
30% or 30 degrees.
Yeah, and so you have, this isn't in full extension, but you have the knee slightly flexed at 30 degrees, and then you're just pushing the patella laterally to gauge the amount of translation. And generally like 1 to 2 quadrants is normal and would just compare to the other knee. Some people are a little tighter, some are a little looser, but can get a good feel. So have the knee flexed, and then especially if they're unstable in deeper flexion, I think that's more concerning, and then more indicative that they're not engaging in the trochlea, and maybe, you know, dysplasia, maybe alta, that they're just not tracking into the groove yet. And the other thing to look at is apprehension. So as you're translating that patella, you know, I would look at the patient's face, and then sometimes they'll just contract their quad. They'll limit your ability to translate it. But that's giving you an idea of, you know, is there, you know, knee resisting that lateral translation as well. And then one thing, so Dr. Allen kind of talked about it the most, but like the MPFL Lockman. So, you know, similar to the ACL where we're looking for an endpoint, this is where we're translating the kneecap. And then sometimes, you know, you can just translate it like 2 quadrants, but there's just nothing at, like, it just feels loose at the end. And that can be kind of a suggestion that the MPFL complex is incompetent. All right, and then another exam finding to look at is the J sign. So with that, you have the patient seated. I'll usually just have them swing their legs over the exam table and then actively flex and extend the knee. And then in extension, the patella subluxes laterally. So as you're seeing here, as she extends, you see the kneecap just pop over laterally. And then when flexing down, it kind of centralizes and tracks normally. And that can be due to VMO insufficiency. You just don't have anything on the medial side pulling that patella. And then can also be due to a shallow or a short trochlea or patella alta. So as the kneecap is more proximally, it's not engaged. And so it just can get pulled more laterally. It can be also due to a large Q angle, so lateralized tubercle. If there's that increased force on the lateral side, it can just want to sit out, and then as soon as it finds the groove, it's central. And then these patients are kind of a setup for recurrent instability because her patella is laterally in extension, and when she flexes down suddenly, it may not find the groove and then may stay out and be dislocated. All right, anybody know who gets medial instability?
People who have had lateral releases.
Yeah. So the most common cause is iatrogenic. And so lateral release or malpositioned MPFL. So if you're, reconstructing medially and it's, super tight that you're pulling it now medially instead of laterally, or medially instead of like keeping it central, then may lead to that. And then one other group of patients.
Ehlers-Danlos or something?
Yeah, exactly. So patients with hyperlaxity. And so if you're talking to somebody with instability, would just confirm that it's going out laterally. It'll be like 95+%. But if they describe medial instability, or you're translating and you can push it medially, would definitely be more concerned. It's going to be a different issue. All right. So in looking at incidence, so the most common age is 14 to 18. Overall incidence of 23 per 100,000. Other studies have shown like 6 to 12, but I think the biggest thing to remember is that age range that we're going to see these in. And it's really that like mid to late adolescence. And then for our treatment, we were talking a little bit about this right after Journal Club before Grand Rounds, but so for non-operative treatment will be our primary treatment for most first-time dislocators. We'll talk about it a bit on the next slide, why, but any thoughts on what would prompt surgical treatment for a first-time dislocation?
I think if they have like a large like osteochondral lesion or like a loose body or something.
Yeah, perfect. So if there's a loose body, osteochondral fracture that should be fixed, or like an avulsion fracture. We talked a bit about getting an MRI after a first-time dislocation. And in general, I'd say it's okay to wait. You probably don't need one. If the patient has a large effusion that's not resolving over the first like 1 to 2 weeks, if they have mechanical symptoms or concern for another injury, then would get it. If this happened a week ago, their knee's calm, their range of motion is coming back, then you probably don't need that MRI, as it probably won't change your management. And then, I think an important thing in counseling these patients is their risk of redislocation. This is out of Minnesota, and they looked at risk factors for recurrent instability and overall found a 20 to 40% chance of redislocation. Earlier this morning, we were talking about, ACL injuries, shoulder instability. And we know that, in those situations, you have a much higher chance that you're going to redislocate again if you're young and after that first-time injury. The patella, though, it can be lower, and your it's much less likely overall that you'll have that second instability event. And then, what they looked at are these different predictors. So if they were skeletally mature, a sulcus angle greater than 145 or 154 degrees, so trochlear dysplasia, and then insol salvati greater than 1.3, so patella alta. And then they broke this out by the probability based on the number of positive factors. If you had 0 of those, your overall probability of redislocation was about 8%. If you had all of those, you were at 79%. So you can really, use these types of, measures to kind of counsel patients on what their likelihood is like for further instability episodes. And so somebody who's skeletally immature, trochlear dysplasia, and patella alta, they're looking at, like 80% chance of recurrent instability, whereas skeletally mature, normal trochlea, no alta, this is almost certainly going to be just a one-time event. Does that make sense to everybody? All right. So then when these patients present with recurrent instability, then we start talking about surgical treatment. Like if it's happening more than once, then that likelihood that it's going to happen goes a lot higher. And then also this can be, I feel hesitant or I feel apprehensive with motions because I feel like my kneecap's going to dislocate. If they've failed bracing, failed therapy, then may talk to them about surgery. And then, so de Jour has described this concept of a la carte surgery. And overall, like the final treatment is still controversial in patellofemoral or patellar instability. But I think thinking about it like this is really helpful, and understanding all of those different components that can contribute to instability. And that a la carte surgery is just saying like, recognize why this person is unstable because it's not always the same cause. And then, target your treatment based on the problem that they have. Don't just say, okay, kneecap dislocated, I'm going to do the same thing every time. On the other hand, you can get good results with just an isolated MPFL reconstruction. So I think this was a really nice paper from HSS and looked at 121 patients with trochlear dysplasia. And they were treated with just an isolated MPFL reconstruction. 4 prior dislocations on average, mean TTTG of 13. So they're just slightly above normal, but not approaching our definitely abnormal range. Most patients had B, C, or D dysplasia. The mean CDI was 1.2, so right at the upper limit of Alta. And then only had 3 subsequent dislocations, 95% return to sport, excellent PROs. I think this really shows that like a well-done MPFL can stabilize the joint for most people, and probably makes sense as like first-line treatment most of the time, versus getting into like osteotomy, bony reconstruction, those types of procedures as like your initial surgical approach. All right, so then when we are doing an MPFL reconstruction, I think, the most important thing is where you place your fixation, or one of the important things. So like we talked about earlier on the patellar side, we'll have 2 limbs with both being above the equator. Just slightly proximal and then at that superior medial corner. And that just reproduces where that native MPFL is attaching on the patella. And then on the femoral side, are you guys familiar with Schottle's point? So that is the radiographic location of an isometric point for the femoral insertion of the MPFL. And it's, here at A, but just anterior to the posterior cortical line of the femur. And just distal to the posterior origin of the medial femoral condyle, and then proximal to Blumensatz's line. And then with this, we'll use this in the operating room. and you need a true lateral, so with the condyles overlapping, and then you can place your tunnel right at this point. And the key thing that you want from this is to be isometric. And so what I'll do for an MPFL reconstruction is I will find this, first I'll try to localize just by feeling those surface anatomy landmarks, and then radiographically use this to place a pin. And then I'll have placed the graft and anchors in the patella already. I'll pass sutures down and wrap them around the pin, and then range the knee to check isometry. So from 0 to 90 degrees, I want that length to be constant. And if it's tightening and flexion or extension, then I know that I'm not isometric and I need to adjust my pin. This point will usually put you close, but I think the key is really that isometric reconstruction from 0 to 90 degrees. Does that idea make sense?
Hey, Dr. Lansdown, does the shuttle point change with trochlear dysplasia? And imagine if you don't have a groove, you're not really going to be in the normal shuttle point.
Yeah, and it can vary slightly in patients, but generally this will put you in the ballpark for that isometric reconstruction.
Got it.
And then sometimes it also, like patellar height will change it. So if you're really alta, that may be in a slightly different location. All right, and then there's also a lot of discussion about repair versus reconstruction. This was a systematic review on studies looking at like an MPFL repair versus reconstruction and looking at outcomes. And they found satisfactory outcomes regardless of technique. And kind of their conclusion was that they recommend repair for a clear avulsion injury, and then reconstruction if there's poor tissue quality. And I think the big thing is, you really, if you're planning for a repair, need to be really careful in evaluating the MRI. Most of the time we're looking at repairing on the patellar side. The MPFL can tear off the patella, it can tear mid-substance, or it can avulse off the femoral side. And if it's avulsed on the femoral side, you put in anchors on the patella and tighten everything up, but it's not firmly attached on the femur, then you aren't going to restore stability. And so need to make sure that you're really reviewing where the location of injury is before just planning on repair on the patellar side. And then in looking at graft choices, there's a number of different studies. This is a systematic review meta-analysis on autograft or allograft. And there's no difference between autograft and allograft in failure rates for adults or adolescents. And they found that autograft is not superior to allograft for MPFL reconstruction. So in contrast to ACL, where we know autograft tissue, especially in younger patients, is superior, the same has not been seen in MPFL. It's likely, because it's extra-articular, just giving like collagen scaffold, and can have good results with allograft. So my preference will usually be reconstruction over repair, and then using allograft tissue unless the patient has other preferences, just because then you're not taking, you don't have donor site pain, morbidity, et cetera. All right. And then when we're looking at additional like realignment procedures, so most commonly will be realigning the tibial tubercle. And this will be with an anterior medialization osteotomy. And this was really described and popularized by Fulkerson. So Fulkerson osteotomy. And this allows us to translate the tubercle medially and anteriorly. The medial translation corrects the patellar tracking, and then anteriorizing offloads the patellofemoral joint. So you decrease contact forces. And then overall outcomes, wide range of studies describing them, but really in that 80+% range of good to excellent outcomes at medium-term follow-up. And then with these osteotomies, so you can change your level of osteotomy cut based on exactly what you're trying to achieve. So just have kind of two examples here, but if this is looking at the tibia and cross-section, tubercle here anteriorly, and then posterior here. So with a 45-degree osteotomy, if you go back to geometry, we can achieve the same amount of medialization and anteriorization as we translate that, since it's 45 degrees. And then contrast that to a 60-degree osteotomy where, so here are 45 degrees. So we can translate the same, and then for every millimeter we go medially, same amount anterior, and we can fix that with a screw. And then with 60 degrees, we'll have increased amount of anteriorization for the amount of medialization. So this is, possibly somebody with more cartilage wear and less lateralization of the tubercle. And so we can offload their joint, bring that more anterior, but then not over medialize their tubercle. You can also go a little flatter on this too, if you need to correct more lateralization. You don't want to translate too much anteriorly. If you go too far anterior, you can have skin problems with closure. But so you could flatten this and achieve more medialization relative to the amount of anteriorization. All right, and then this osteotomy, I think, can be really powerful. This is kind of the different corrections you can get. So medialization, I think I will use their pre-op TTTG as my guide, and then a final measurement as their intraoperative tracking. Abnormal is more than 20, borderline 16 to 20, and normal 10 to 13 millimeters. So based on what their TTTG is, I'm shooting to get them into this 10 to 13 millimeter range. And so based on my measurement pre-op, I'll say I want to shift this 8 millimeters, 10 millimeters, 12 millimeters, et cetera. And then with this, you're shifting the cartilage contact medially. Then the anteriorization would base this on the cartilage appearance, both on imaging and then with your initial arthroscopy. This will offload the patellofemoral joint. And then importantly, this shifts the cartilage contact from distal to superior. So if you have somebody with superior patellar wear, maybe a relative contraindication because you're going to just overload that area and may make them more painful. And then with the same osteotomy, you can also distalize. And then I'll correct this based on their Caton de Champ. And for patella alta, so greater than 1.2, 1.3, bringing the tubercle down can help the patella engage sooner. And then you do risk patella baja and limited knee flexion with overcorrection. So I'll make all these measurements off the preoperative imaging and have an idea of, okay, I want to shift them a centimeter medial, 5 millimeters distal, and then make the osteotomy at my intended angle, shift the tubercle, pin it in place provisionally, and then check tracking. And then do I like where the patella engages? Is there, are they centrally tracking, et cetera? And then can fix in that position. And then if it doesn't look like they're tracking well, if they're overcorrected, undercorrected, et cetera, shift again, pin, check, and then fix. Does that make sense? All right. And then, with patellar cartilage injuries, we'll kind of skip through some of this because I think you guys touched on it last week, but can be either a traumatic cartilage injury or atraumatic wear just from abnormal alignment. Would always ask if they have episodes of instability, like do you need to correct instability in addition to restoring cartilage or treating the cartilage? And then I'll ask them, I think the most important question is if they have pain and swelling just when they dislocate or sublux the patella, or do they also have it in between instability events? So the joint will be painful, swollen for probably a couple days after a dislocation at least. But is this like, I have periodic dislocations, but in between, whenever I try to do anything, I have a large amount of swelling at my knee. That would really suggest that they likely have abnormal cartilage. And then we'll skip through this as this should have been covered, and then kind of talk about two cases real quick. So the first 24-year-old man, he presented with right knee pain. He pivoted on a rug and dislocated his patella. And he describes 5 to 6 prior patellar dislocations. His last one was 4 years before this, and then his first was in high school football. He was hit, patella came out laterally. Before presenting for evaluation, had tried formal physical therapy, bracing, taping without relief. And then his exam, so he has 0 to 130 degrees of motion, 3+ patellar translation, positive apprehension, and a negative J sign. All right. So lateral x-rays here. What do you guys want from our x-ray?
Measure the CDI.
Yeah, perfect. And then we can also look at our kind of our trochlear morphology on his x-ray. We'll see it on his MRI too. And then, so his CDI is 1.18. So approaching the upper limit of normal. And then what do you all see on his MRI?
Trochlear groove looks fairly shallow.
Yeah. So I'd agree.
There might have been a cartilage injury there. It's hard to say.
Yeah, I think his cartilage all looks fine.
Okay.
And then, so this is his
MPFL.
MPFL looks torn.
Yeah. And then what else would we want from our MRI?
Or TTTG we could calculate from.
Yeah. And so his is 16. So what would you do? Let's see, Alex.
Well, let's see, CDI is like, within an appropriate range. It's less than 1.3. TTTG, not normal necessarily. It's not like fully past the abnormal, which I know we think of as greater than 20, but he does have like a torn or at least attenuated MPFL with like multiple repeat dislocations. And so I think I would do like an MPFL reconstruction in this person.
Yeah, perfect. So, he has trochlear dysplasia, borderline alta, and then slightly lateralized tubercle. So this is exactly, the patients that they looked at in that HSS study we talked about. But I think we can expect very good outcomes with an isolated MPFL reconstruction. So using allograft, our 2 points of fixation on the patella, both above the equator, femoral socket at Schottle's point. So I'll put the pin in, localize that with fluoro. And then after it's in, I'll just put my clamp there to ensure that it's right there, and then check isometry. And then fix on the femoral side with the knee flexed at 30 degrees. And then in our last minute, one last case. So this is a 30-year-old woman, bilateral patellar instability since childhood. Right side is currently worse than left. She has intermittent dislocations at both knees, pain and swelling just around the time of instability, not between. And then she's not even sure how many times they've dislocated. On exam, her right knee, she can only extend to 10 degrees, but full flexion, and then she can fully extend on the left side. She has 2+ lateral translation with guarding and apprehension, 45 degrees of internal rotation bilaterally, has a positive J sign on the left, and she can't reach full extension on the right, so can't really assess that J tracking. So this is her imaging, and it's a dysplastic trochlea on the right side, and then just to go through, so her CDI is 1.24, TTGG is 16, and then her TT-PCL is 25, so above normal there. So what I did for her, let's see, we'll try to. So you can see, this is just me flexing in the operating room, and then this is her patellar translation. So she has she's unable to reach full extension, but has a very positive J sign. So treated her with AMZ osteotomy, MPFL reconstruction. So she has that kind of borderline lateralization. She's so small though, and her patella tracks so abnormally. Do think in a patient like that, this osteotomy will give more predictable results. All right. So
Why do you think she lacked full extension?
It was so painful for her to straighten out. Like as soon as she was asleep, it was full, but she would just dislocate in full extension, and she was so apprehensive to go in that position.
I see.
She's a couple years out now and doing great. And so anatomic variability can lead to pain, instability, cartilage problems. And then with the patellofemoral joint, you really want a thorough assessment of the entire lower extremity. You want to determine the primary cause to be able to correct it. And then these are kind of our treatment options, less so on these last couple for instability, but something to keep in mind, especially in revision settings. All right.